Welcome to our podcast, The Better You Are, The Better You Are. Whether it is physically, mentally, or spiritually, when you know better, you can do better. And when you do better, you'll be better. On this podcast, we share knowledge, expertise, opinions, and experiences. All things that can help you to change the game. By the time we're done, it's hard for you not to be encouraged. So join us. The better you are, the better you are.
Our speakers today include Dr. Regina Adair. Dr. Adair is the Regional Medical Director for TeamHealth's OB-GYN Hospitalist Northeast and Indiana markets. She is also the Facility Medical Director for the Indiana University Ball Memorial OB-GYN Hospitalist Program. She has more than 20 years of experience in the field of obstetrics and gynecology. Next is Dr. Ann Matory. Dr. Matory is a neonatologist with 40 years of experience, having worked in neonatal intensive care units in Chicago, Atlanta, and now in Indianapolis. She is currently the medical director of the neonatal intensive care unit at Eskenazi Hospital in Indianapolis, Indiana, and is also a faculty attending physician at Riley Hospital Neonatal Intensive Care Unit. We also have Sierra Woods. Sierra is a postpartum registered nurse, international board certified lactation consultant, postpartum doula, and an Indiana certified community health worker. She is founder of the Melamama Maternal Wellness Program in Indianapolis, Indiana, focused on providing accessible lactation care for women of color in underserved communities. We also have Dr. Ann Osuntokun. Dr. Osuntokun is a pediatrician with 27 years experience. She is with Peyton Manning Children's Hospital and the Ascension Medical Group in Indiana and has been with them for the past 21 years. She takes care of children from birth to young adulthood at the age of 21. We also have Dr. Tamika Dawson. Dr. Dawson is a highly experienced family and sports medicine physician based in Indianapolis, Indiana. She also has some 20 years of experience and is a course director at the Indiana University School of Medicine. And I am Dr. Lauren Dungy-Poythress. I am a maternal-fetal medicine specialist, which means that I specialize in high-risk obstetrics, and I have decades of experience as well and have worked with different programs throughout my career, including here in Indiana, as well as other states. What I love about this panel is that it includes people and professions that I would reach out to in order to help care for women throughout a pregnancy. Okay, so now let's start talking about during pregnancy. The better you are before, the better you will be during. So the better you are during pregnancy, let's talk about that. And so we talked about hypertension and diabetes. Those are risk factors for preeclampsia. Dr. Adair, somebody presents to your office. What do you tell them about preeclampsia?
So preeclampsia is a disease of pregnancy only in humans, which is surprising. However, it is, by definition, blood pressure of 140/90. You don't have to have both numbers together. You can have consistently the top number, which is your systolic blood pressure above 140, and the bottom number is your diastolic blood pressure, and that has to be over 90. There is something, it affects your kidneys, it can affect your liver. And so with your kidneys, we look to see if you spill protein. So normal healthy kidneys should not pour protein in your urine. But when they're affected by preeclampsia, there is a spillage. And so 300 milligrams per deciliter is considered preeclampsia.
So that's why they're always asking for a urine sample when you come to an OB
So when you come for your visits, you always have to pee in a cup, okay? Blood pressure and pee in a cup. Those are the two main things because we always look for the most likely bad disease in pregnancy. And so pregnant women are at increased risk. They're at increased risk if you have diabetes, if you've had hypertension previously, if you are old, like I was when I had my children, and younger people in first pregnancies, multiple pregnancies. So if you have twins, triplets, that increases your risk also. So those are all the things that's why it's imperative that you come and get evaluated early on, because we can, determine, those are two babies in there, not just one. And so these are things that I can counsel you about early on in pregnancy. So those are the things that we look for in your prenatal care.
Yes, and I tell people we don't know what causes preeclampsia. We know it only comes with pregnancy. The cure is delivery. Sometimes we don't want to do that right away because we care about this baby inside. But we don't know what causes it, but we do know risk factors. And just to reiterate those risk factors, it's if you're older, as she points out, or younger, or if you have more than one placenta. There's something about having a placenta inside. And the more you have, the more you're at risk. Any underlying condition like hypertension, diabetes, or lupus, et cetera, can make you at risk. So, and that's why it's important to see your doctors beforehand. But now that we're in pregnancy, well, how do you counsel patients about preeclampsia or anything they might do to help reduce those risks?
So if we determine they have risk factors early on, around 16 weeks or so, we will put them on a low-dose baby aspirin, which is like 81 milligrams, that chewable aspirin, and that has been found to decrease the incidence of preeclampsia in people at risk.
Can I just say that I have people come to my office and I say, "What? Do you know why you're on that aspirin?" And they'll say, "Yeah, for my blood pressure." And then people who don't have high blood pressure say, "Well, I didn't take it today because I don't have high blood pressure." You're not on it for your blood pressure. You're on it to reduce the risk of preeclampsia later on in pregnancy. And there's something important about taking it early on in pregnancy, beginning at 12 to 16 weeks when the placenta is forming, because it has something to do with that placenta. So 12 to 16 weeks, it's very important to take it then, take it once a day, and to keep taking it so that when I'm old enough to know that when we first did studies with aspirin, they said, "Oh, it really doesn't have an effect." Then they went back and looked at it, and what it did was it pushed it out when it happened. So, Dr. Matory, if it happens at 28 weeks versus 32 weeks, is there any difference in that for a baby?
Definitely. We worry then about prematurity and all of the potential complications. 28-week babies are likely to have respiratory distress. All of these babies who've been exposed to high blood pressure, preeclampsia, are subject to be small. They don't grow well. And as a result, all of their organs are smaller than they should be for that particular gestation. If you can get the mom to 32 weeks, we like that better because there's less respiratory distress syndrome. There's, better growth.
What is respiratory distress syndrome?
Respiratory distress syndrome in the past was called hyaline membrane disease. It's the respiratory illness in premature babies. And as a result, they have difficulty breathing. They frequently have to be intubated and placed on ventilators and receive medications to support their respiratory status. The further along in pregnancy that the baby gets, the fetus gets, the better it is for those lungs to develop and for them to have less, if you will, respiratory distress. It's not written totally off the slate, but it certainly decreases the further along the pregnancy gets.
Is it fair to say that breathing or the ability to breathe for a baby is one of the primary things that affects its health? And so the better a baby is able to do that.
Sure, most definitely. Because if you think about it, breathing means that you take in enough oxygen and you get rid of enough CO2, carbon dioxide. The entire body needs adequate oxygenation. Most importantly, brain, heart, lungs, and the intestines. The rest of the body also, but those organs, they have to. If they don't get adequate oxygenation, then they basically don't function. And that's when you have babies with neurologic issues, if the brain has been compromised and did not receive adequate oxygenation. The lungs then are compromised. They don't function well. The heart can be affected. Just as we see in older patients and adults, we worry about the heart and being able to function appropriately and adequately because of the oxygenation that the heart needs. Every organ needs it. And so if it's a baby who's having compromise based on respiratory distress, every organ can be impacted and affected.
And Dr. Adair, you talked about that's what we look for as doctors and for women. And we look for that more frequently later on in pregnancy, which is why we see patients more often. Can you talk about that?
So in prenatal care, when you first find out you're pregnant, we go through this myriad of testing, and we look for diseases that we know can affect the pregnancy, either immediately or long-term. So your visits usually are every 4 weeks until you are 28 weeks. At 28 weeks, that's when preeclampsia, you're considered to be in the third trimester. That's when preeclampsia is most likely to occur, in the third trimester. So even though you're pregnant for 40 weeks, the major happenings occur every 3 months or so. And so that is why it's divided into trimesters. So that's why people think they're pregnant for 9 months. No, you're pregnant for 10 months. And everybody's like, but I'm 9 months pregnant. I should be having a baby. No, not yet. You have a little bit more time. So at 28 weeks, we start seeing you every 2 weeks. And then at 36 weeks, we start seeing you every week. Because the closer you get to delivery, the greater the risks of poor outcomes from preeclampsia are likely. And we do some testing at 28 weeks to check for diabetes. 26 to 28 weeks, depending on your risk factors prior to pregnancy, it may be a little bit earlier, but we do some testing for diabetes also, which we know increases your risk of preeclampsia. So we monitor you more closely as you get farther along in your pregnancy, just to intercept those potential ominous situations and opportunity for us to do something about preeclampsia. Preeclampsia isn't the bad thing. It's eclampsia, which is terrible. And that is where you have seizures caused by this elevation in blood pressure. So what preeclampsia is our opportunity as OBGYNs to intercept it and deal with it. And as Dr. Lawrence said, the cure is only delivery. You have to get that placenta out. And we do our best in the time frame that we're taking care of you to optimize both the mom and the baby. But there becomes a time where it's better for the baby to be out, even though it's premature, than to be in that environment where it's not getting the nutrients and oxygen that it needs because of the elevated blood pressures and the other issues with mom during the pregnancy.
Yes, I tell patients, if you get bad, your baby's going to get bad. And if you die, and that's a real concern, and that's why it's important to be seen and be evaluated. We often look for signs and symptoms, or we ask patients questions all the time about preeclampsia. What are some of those concerns or symptoms we're looking for?
So it still is hypertension. So it's usually the same signs and symptoms that you see when you're not pregnant. So we always ask, do you have a headache? Well, yeah, I have a headache every day. Okay. Do you have migraines? Well, no, not really. Have you taken anything for your headache? Yes. Did it work? No. So you took everything that you would normally take, and this headache is just, I can't get rid of it. I don't feel well. Do you have blurred vision? Are you seeing spots? I don't know if anybody ever played that stupid game when you were a kid, when you bend over and hold your breath and stand up, and then you kind of pass out and you see the little spots in your eyes. It's kind of like, that's what we're looking for. We're asking, are you seeing spots? Do you have pain under your right boob? That tells us that you're having an issue with your liver. Your liver is located right under your rib cage, under your right boob. And so if you have pain under there, that tells us that you might be a person who has severe preeclampsia, and that is a more ominous sign than anything else. Do you have swelling in your hands and your face? Swelling in your feet and lower extremities is normal in pregnancy because the big blood vessel that brings all the blood from your lower extremities is compressed or squeezed by the big uterus. And so if you stand up all day like we do, then it's going to settle on your feet and it can't make it back up. But you shouldn't have swelling in your hands and your face. And then do you just not feel well? Sometimes that is what people describe. It's not necessarily all those specific complaints. It's just like, I just don't feel right. It's just, and those can sometimes be the signs that we need to investigate further.
Now, Sierra, you said you had preeclampsia. Did you have those symptoms?
I did. Well, I didn't have all those symptoms. That's why it was weird. Yeah, so when I found out I had preeclampsia, I remember being at work and I did not feel good. Like, I just didn't feel right. My hands were swelling, but I wasn't quite sure, just because you feel like everything's swollen. And I remember going to another floor, and one of my friends was working on another floor, and I called her. I said, "Hey, girl, when I get to lunch break, I want you to take my blood pressure just to see what it is." She took it, and she was like, "Sierra, I don't want to tell you what your blood pressure is." And I was like, "Well, that just scared me." And she was like, "Well, let me just call the charge nurse and have her take it." And I was like, "Okay." Took my blood pressure again. She was like, "Sierra, you have to go to the hospital." My blood pressure was 140 over 100, 170 over 100. And she was like, something's wrong. So I remember calling my husband, like, "Okay, I got to go to the hospital. Something's wrong." Went to the hospital. You know, they do the urine sample. They did the blood pressure. They were like, "You know what? You have preeclampsia. We're going to go ahead and induce you now." So that whole process was very scary because I hadn't even packed a bag. I was 38 weeks. So I just thought, oh, I got 2 more weeks. I still got time to pack. I'll be all right. And I didn't. I just had to get there and end up being there. And I think I got induced on a Thursday, ended up having him Saturday. So
I think that is an important factor, as Dr. Adair points out. You just don't feel right. People tell me I didn't want to call my doctor. We wear pagers, and there's nurses in the hospital 24 hours a day, and doctors hospitalists covering 24 hours a day for that very reason, to contact your doctor or somebody. Just go to the OB unit or the ER and say, "I just don't feel right." No shame in saying, "I just don't feel right. And then check your blood pressure. The risk for stroke is greater, blood pressure greater than 160. You had 170. God is good that you did not stroke. But that's what we want to know. We want to control it quickly and treat you and your baby well. Anything else we need to address on preeclampsia, or any thoughts anybody wants to add before I move to a next section?
I would just say that there's a higher incidence in African Americans. And so we need to pay attention to that. Listen to our bodies, that, hey, if you don't feel right, you need to go and get checked.
Yes.
And you can't worry about wanting to bother your physician or whatever. Go to the hospital. You can never go wrong making sure that everything is okay. So,
Excellent point. Because if you stroke at home, you die. Unfortunately, that's not worth the little bit of inconvenience or embarrassment, or even if the people at the hospital are sort of jerky. It's your health, it's your baby's health. Make sure you go and be seen, and that things are taken care of.
and we all, I'm sure, heard about the recent loss of that world-class track star who died at home from eclampsia. And I'm sure she had signs and symptoms prior, but blew them off or just didn't want to bother people. And so you have to pay attention. We know when we don't feel right, right?
Or perhaps didn't even know that those were the signs and symptoms, which is one of the reasons we're doing this today, so that we can help educate people to know. Okay.
Yeah, I usually tell people, listen to your gut feeling. If something says something's not right, believe it, and contact your doctor, or go to the nearest hospital. Contact someone that is like your loved one or family member. Let them know, because I think a lot of times we just think, oh, I'll just go lay down. But what if you don't wake back up?
Very good. And to your point, you didn't know your blood pressure was high. You just know you didn't feel right. So you got to have a blood pressure check to know what that's doing. Well, what I'd like to talk about now are other important things that, and I should point out, the first trimester, that first part of pregnancy, when people think, oh, maybe I can't get in or don't want to go see a doctor, but I'm pregnant. But as Dr. Adair pointed out, we can start that baby aspirin early in pregnancy that might reduce the risk of preeclampsia. But there's other conditions that we won't know unless we screen for it. And two of them more significant growing concerns in pregnancy are syphilis and HIV. And so, Dr. Adair, if you could talk about how that's evaluated and treated, and then Dr. Matory, if you could talk about concerns for babies that have that and why it's important to get treated in pregnancy so your baby's not as affected.
So when we talk about your first initial prenatal visit with your doctor, that is the time where we do all the counseling and do all of our blood testing. We test for multiple STDs. Syphilis, unfortunately, is
What's the STD?
a sexually transmitted disease or infection now, they're calling it. You know, I'm old, so they called
I'm
it
old too.
disease back then. But it is, there are certain ones that can affect your baby. So syphilis, unfortunately, is coming back in full force in the United States and in our communities here in Indiana. And so that is something that we test with the blood test. Depending on what your lab uses, it can be a RPR, I don't know what the acronym is for that, or a VDRL. Those are blood tests where they check to see if you have an increase in those levels, and if so, they will confirm that to see if you have antibodies in your blood. And if you do, that requires shots, 3 shots of penicillin, which aren't pleasant, but absolutely necessary. And if those, if your baby is born with syphilis, considered congenital, meaning that it was contracted during the pregnancy, it can have detrimental effects to the baby.
Absolutely, but we can significantly reduce those risks by identifying that you had the infection. So you need to come in and see your doctor and be tested, and treating you with some simple, painful penicillin shots.
Absolutely.
Okay.
Same thing with HIV. We've been blessed to get medicines now that decrease the transmission in pregnancy, and so I'm
Decrease.
sure.
Did you say increase or decrease?
I said decrease.
Okay.
Yeah.
I'm sorry.
Decrease the transmission in pregnancy. And as Dr. Dawson can probably speak on, that now viral loads, which is how much of the virus is in your blood, can be undetectable, where you can't find it in blood. And those are the times where we decrease the transmission in pregnancy. And so if you get that blood test early on in pregnancy and are found to be HIV positive, we can give you medications that almost make it impossible for your baby to end up with HIV after they're born.
That's so true. The incidence can be very low. We decrease the viral load. We can even now allow vaginal deliveries. Maybe Dr. Matory could speak more to it, but I've not seen a baby born infected when we had a really well controlled throughout pregnancy. And if we don't know, if you're not in there, we're not getting tested, we can't identify that. Did you have any comments, Dr. Dawson, on? I send people to an ID specialist but you might have some.
So here in Indiana, we have Life Care, which is really wonderful. It's a team of nurses and physicians who take care of our HIV patients. And so what we've seen a lot is that a lot of patients who take their medicines are really well controlled and are undetectable, which is great. I have a couple of patients who have contracted it when they were really young and who have had healthy children and have done completely fine. HIV has become more of a chronic disease state than it was 20 years ago. 20 years ago, it felt like a death sentence. And now I've seen patients who have had HIV for 20, 30, 40, 50 years, which is really, really nice to see. And so if they're controlled, I have a 75-year-old who's had HIV since he was in his 30s. And so it's amazing what has been done. And so the biggest thing is to try to counsel your patients to take their medications. That's the biggest factor.
And one thing I just want to make sure everybody is aware of, a lot of women don't get early prenatal care because they think they need to have insurance. No. Prenatal care is free. So you call, you set up, you might not have insurance or whatever, and retroactively, meaning that after you have been seen by your doctor and everything, the insurance, Medicaid, or whatever insurance that the state can offer you will be instituted and the doctors get compensated. So it is free. Prenatal care is free.
Dr. Matory, do you have any comments on what could happen? Why is it important to treat a woman in pregnancy to help reduce the risk of an infection of syphilis or HIV in babies?
Yes. Those two infections, of course, we hear quite a bit about, but any infection that you have when you're pregnant can be transmitted to the fetus. And as a result, the baby can be born with the infection. Syphilis we worry about because it can affect, once again, the entire baby. The brain, we have what's called neurosyphilis, so that's just involving the neurologic system in the baby. It can infect the heart. It can infect certainly the bloodstream of the baby. And what we need to know, based on tests that are done during pregnancy, we take those mom's titers, those levels, and then we check it against the babies. And we look to see if mom has been adequately treated. It may very well speak to the fact that the baby then is negative and doesn't have the infection, or titers may be lower, and then we need to follow, or the same, and if they're higher, we're going to have to treat the baby. And that also involves penicillin. It involves a longer stay in the NICU, but it's important then to rid the baby of the infection. HIV, as you point out, as we see moms receiving treatment, then delivering babies, babies get started on treatment. However, we see that in the 3-6 months, we're able to check and their levels are basically non-existent. And so getting that treatment during pregnancy, those moms who get the treatment can make such a difference for the outcome of their baby.
Indeed. And as you point out, any infection, but herpes is another one. There are conditions that, for example, and Dr. Adair can speak more to this, but if it's not well controlled, we're going to recommend a C-section as opposed to a vaginal delivery, which is oftentimes much easier on the mom and long term.
So in herpes simplex infection, I think the stigma is that simplex 2 is the bad one and simplex 1 is the okay one, because 2 is the one that's associated with a genital infection, whereas 1 is associated with facial, oral, cold sore. But they can be either place, and they have the same problematic outcomes in pregnancy. So if you have an active outbreak at the time of labor because of the risk to the fetus, we recommend a C-section. As the baby comes through the birth canal, it can be infected and have sequelae afterwards. So not controlling that, which we typically at 36 weeks, because most people don't go into labor until after 36 weeks, we put them on some type of suppressive therapy, and that's medicine to kind of keep the infection away. And we recommend that if you are a person who actively has frequent outbreaks, that you just take your medicine all through pregnancy. But for some folks, stress is an initiator of those outbreaks. And if that's the case, you're more stressful 36 weeks trying to get a house together, family together, all those things. So we recommend some type of suppressive therapy at 36 weeks.
And since you mentioned stress we know can be risk factors for so many things in life. It can be for high blood pressure and complications that your patients see. It can be for preterm labor and preeclampsia and things that we see. I'd like to talk a little bit about preterm labor. What are some signs and symptoms that we want to tell patients that they should look for that might be a sign of preterm labor?
So preterm labor by definition is delivery between 20 weeks, which is 5 months, and 36 weeks and 6 days. For us as obstetricians, full term, even though your due date is based on 40 weeks, full term for us is 37 weeks. So any pregnancy between 37 weeks and 40 weeks is considered a full term baby for us. The situation with preterm labor and some of the issues are the same with any preterm delivery. The consequences are more for the baby than the mom. And what we look for are risk factors. If you've had a preterm baby previously, you're at increased risk of having another. Infections increase your risk significantly. Usually infections in the uterus or in the membranes that surround the baby and the fluid increase your risk. So that is why we are diligent about addressing infections and treating them aggressively. A common infection is a urinary tract infection. So urinary tract infections in pregnancy, the bad part about them is that they are usually asymptomatic, meaning that you don't have any symptoms. Most people complain, I go to the bathroom every 5 minutes and only a little bit comes out. I always have this burning and stinging in pregnancy, you can be infected and not have any of those symptoms, and it can cause preterm labor. So we are very aggressive in checking that. So that's another reason why when you come to your visits, you have to leave a sample of your urine, because we test for bacteria and signs and symptoms of urinary tract infections based on that also. So
what are some symptoms that patients might feel, or do you counsel them to look? Well, I'll just tell you, like I counsel patients, sometimes you feel cramping, you don't know what it is. Sometimes you just feel a tightening that comes and goes. It just feels like maybe somebody's wrapping a belt around you and then taking it away. Or you feel a lot of pressure vaginally, or you have
abnormal discharge.
Yes, thank you. And so anything that, again, just doesn't feel right, or those things, I wonder if this is labor, don't stay at home and wonder about it. That's why we're in the hospital all day, all night to come in and screen for that. And unfortunately, we know that Black women are more at increased risk, again, related to a lot of factors, and stress is a factor. And what might be stress for me might not be stress for you, but we're all under some element of stress. And we know that prematurity and the complications associated, unfortunately, affect Black women more. And so we need to be more diligent about it. And that's why we're here educating people about it today. Sometimes we give things for preterm labor. We can't really stop it real well, but we can halt it enough to give some things that might be important to help Dr. Matory. And if we do have to deliver a baby prematurely, what are some things we would do for preterm labor?
So if there is a young woman who's at risk of preterm labor, our first line is, number one, is what can we do to help this baby? So we give steroid injections. They are a big old shot and a big old muscle, 24 hours apart.
Did you get one?
Mm-hmm. Yes.
I hear they hurt. I never got one myself.
It's
I
not
heard they really hurt.
It's not pleasant, but it's essential. It's essential. And so we give a steroid injection, which helps those cells that make the substance called surfactant. It helps them to start making it earlier than it should, so that the lungs for babies can start to function and exchange oxygen like it needs to. That's one of the first things we do. Because true preterm labor, there's nothing that we can really do about it. We do our best to hold it off as long as we can so we can get the steroids on. There's a medication called magnesium sulfate that used to be used for everything. It was the end all be all. That magnesium sulfate is a medication that we give. It reduces the contractions of the uterus, so sometimes it can help. But also what it does is we use it for neuroprotection. And some of the consequences of prematurity aren't just lungs, but a brain bleeds. And that's why some babies later on end up with some type of neurological deficit. So what that does is it helps to decrease the incidence of that. So we give that up until 32 weeks.
We also give antibiotics.
And antibiotics, yes.
And
because the most likely reason for preterm labor is some type of infection. And so we empirically treat, meaning that we treat everything that is the highest incidence of an infective pathology.
And Dr. Matory, as Dr. Adair pointed out, we give some things to help the baby that we think is going to be delivered early. We give betamethasone, we give, which is the steroid injection, we give magnesium to help with some things, and we give the antibiotics. Can you tell us why that's beneficial, or just sort of explain why somebody wants to get in time to at least get that started for their babies?
Yeah, as mentioned, the steroids help the baby's lungs then develop their surfactant. And the surfactant is a sudsy, soapy substance that's in the lungs. We can also give it after the baby is born, but if it's given ahead of time, our hope is that the baby will have less of the respiratory distress syndrome that I mentioned.
And so that betamethasone helps that develop and work better. So we're giving something to help what's going to naturally occur after delivery.
Exactly. And the fetus gets that, based on the shot that's given to mom, and then the newborn after delivery has lungs then that are hopefully going to work better, is the bottom line. If they don't have enough of the surfactant, then the lungs will perhaps open partially, but then they collapse and then they don't open again well. And so these are the babies with significant distress.
It's sort of like blowing a balloon, isn't it? Or how I've heard it described, where you got that brand new hard whatever balloon and blowing on it. But once you've blown it up a couple of times, it blows up much easier. I don't know if that's a good way to explain it. But.
Yeah, definitely. And it's a part of the process. And we see when we first, for example, start to resuscitate and take care of babies in the delivery room, that it's difficult to initially get their lungs to open up. But then if they have the surfactant developing, if they receive the steroids, then it gets easier. In the meantime, we put them on a ventilator, we give them extra support. But having that surfactant in place is crucial, either during the pregnancy by way of the steroid injections to help develop it, then also we can give it after the baby is born. We give actually artificial surfactant, if you will, in the nursery. The one thing I will add is that with everything that's happening, especially during the pregnancy, and then once mom comes in for delivery, we get consulted, and we really want to be a part of that story and a part of that picture. And then we meet moms, and we can help them to know what to expect, because when you get pregnant, you're going to have a baby, you expect deliver, home in 2 days, right? Not the case with premature babies or babies who have infections or other things that have to be dealt with. And so we in the NICU can have those conversations early on. And I think that helps to prepare the family. It's not the same as when it happens, but it does start the conversation with them.
Awesome. And I like your thing about expectations. And so many times in life, it's about the expectations. And it didn't happen the way we expected it to. And I know that my friend here, Sierra, is a doula who helps, and doulas can help manage through pregnancy. She's a postpartum doula. I'd like her to talk a little bit about both. But sometimes it's just helping you understand the expectations. So I'd like you to talk about what you do and how does somebody get a doula, and what services are available.
Okay. Yes. So I'm a postpartum doula. I'm sorry. So what that means is I help new parents when they get home after they've had their baby, whether that's helping with tidying up the house, holding the baby so that you can take a nap. If you're bottle feeding the baby. It's literally anything. Even if you needed me to run to the store, like I will run to the store for you and pick up the things that you need.
Can I just say something? So when I delivered, I thought, and granted, I've been a high-risk OB doctor for years. I thought, I'm going to have time to read my journals. I'm going to sit between, 4 hours. I'm going to do all this stuff. I breastfed, and so that feeds faster. And I kid you not, 15 minutes a day, one time a day, to decide, should I eat, should I sleep, or should I take a shower? And so that running to the store, the expectations. And so somebody like a doula or family member, anybody who's going to help you through that is beneficial. I just wanted to express that for people who, if they were ignorant like I was about what it's like taking care of a newborn. So go ahead.
So postpartum doula. But with a birth doula, they actually help with during your pregnancy and your labor. So they are really good with providing support and extra help. So maybe you decide you don't want to do any type of pain medication. So they might help you with trying different ways of like laying on a ball or bouncing on a ball, or they also help supporting your partner with ways to help you as well. So they might show your partner how to help support you with maybe pressure points on your back or different things like that. The best time though to look for your doula is when you find out that you're pregnant, because usually doulas fill up pretty quick. And then also another way to find a doula though would be to think about, do you have any friends recently that had a baby? Ask them, who was your doula? So check around first, and then also you can ask your OB.
Dr. Adair, as an OB-GYN hospitalists. Do you work with doulas?
Yes, we have doulas that, well, COVID kind of interfered with that because they had limited amount of people, but there are doulas that are available and are very supportive to the moms during their.
So you guys work together, sort of as partners.
Yes, we partner together, yes.
Yeah, and so it's not necessarily an adversarial. Sometimes I've heard of, you know,
Not at all.
the doula wants one thing and the doctor wants something else. They're working together to take care of the patient and give them the best care.
And that also reminds me, a lot of times I've seen now there are hospitals that have hired doulas. They have doulas on staff that work in the hospital. So you can even just check out your local hospital to see, oh, are there doulas that are already on staff here that can help me through this pregnancy?
And I'm sure that sometimes they cost money, sometimes they don't, but there are resources and things that are available to when you can't necessarily afford it.
Can you reach out to doulas if you're not pregnant? You know, if you're thinking, I would like to have a doula, I'm hoping I'll get pregnant in the next year or so, can you start that process?
You
ahead
sure
of time?
can. You can always start the process with finding a doula.
Hey, let's talk about this. So maybe you want to be a doula. Maybe you've gone through a pregnancy or you want to reach out back and help somebody. What kind of process did you go through to get trained?
Yeah, so you can act. I say if you decide that you want to be a doula, you should first find a doula that's already doing it and talk to them about what it's like being a doula.
Good advice.
Yes, because you don't know it till you're there, and then, you know. So I would say, yes, start there. First ask around, see who's already a doula, get the advice from them. Then there's so many programs online that you can actually go through to learn to be a doula. There's in-person and there's virtual ones. So there's plenty of scholarships. I actually found a scholarship to become a postpartum doula that paid for me to become a doula. So it's so needed now. I feel like right now I'm hearing about a lot of people saying after they have their baby, oh, I want to be a doula. I'm like, well, there's plenty of scholarships out there available for you to become one.
That's great.
Yeah, it also could serve as two roles. Also being an advocate for you in the hospital.
Yes.
So, because a lot of people go into, when they have their baby, they don't really have family members or, spouses or partners that have experience with health. So having a doula could be also part of that.
I think that's great.
Experience for
And
you.
that's so important. And it's important to have an advocate. And sometimes you're very vulnerable or very in a position you don't seem to have any of the power when you're there in labor. You want a good relationship with your OB-GYN doctor. You want, anybody, a mother, a grandmother, somebody there who can listen for you, because you're not necessarily listening to what people are saying to you. You're in pain and other things. And so to just help you think through things and to manage things.
I also want to state, so I know, we oftentimes, a lot of moms are saying, I don't know if I can afford a doula. Many times doulas do sliding scales, they do payment plans. So it's more so you got to meet with them and talk to them about like, what are your goals? Because you can actually hire a doula just for the birth of the baby. And you can hire a doula for like the beginning, before you get pregnant, during like for the whole, they have packages. So just talk with doulas first before you just completely say, nope, I can't afford it. I'm not going to do it. First, check around and see if they can work with you. Because a lot of times they want to help you.
Yeah, that's true. They do. They really do. I
wonder
know.
if it's covered by insurance.
So they're working on it.
And the more the word gets around, maybe they'll have to, but we'll see.
They're working on it.
But that's all good advice. Were you going to say something else?
No, I did have an experience with a premature. I get.
And I was going to say, so we're a group of 6 Black women up here. We know that Black women have increased risk for preeclampsia, increased risk for preterm labor. You mentioned you got a steroid shot. She got steroid shots. That's because we're concerned something was going to happen. Sierra had preeclampsia. Dr. Dawson says probably was on the way to preeclampsia.
The one message that I would want to share is similar to, you know your body, right? And so I thought that I had ruptured, my back had ruptured, and I went in, and the first person who examined said, no, I don't think so. I said, no, I think it has. And I also had some bleeding, and they were kind of dismissing it. I said, no, this isn't right. I haven't had this before. I stayed, and sure enough, it all came to pass, and I delivered. I had a baby at 36 weeks who did okay. But those were early signs that were being somewhat dismissed.
Right.
But I knew it was not right.
So don't give up. Don't necessarily, just keep pushing. What was your experience, if you want to share?
My experience was, we were on our way to Mexico, 22 weeks. And I just felt contractions. I would use the word contractions because it was my third child. I did have a bit of experience. And I was cramping. So I called the OB, and she said I needed to come in. And she says, you started to go into labor. So I had to be admitted. I was admitted for a couple of days. I got IV injections. I can't even remember what they were. I had the talk from the neonatologist. These were colleagues. And they came into the room with their heads down and saying, you may be having a baby very soon. And I realized that I just didn't want to hear that. I was more in denial. My take home from that was, listen to your body. I was working so hard. I was a pediatric hospitalist at that time. And I was on my feet all the time. And I just didn't pay attention. And I had other children as well. So I think the take home for all of us, especially women of color, is, we are so busy. We're doing a lot. We're multitasking. We're dealing with stress. We're dealing with stress at home. We're dealing with stress at the workplace. And I think we are such givers. We give a lot, and we don't spend time on ourselves. So I think we really need to pay attention to our body. We need to eat right. We need to get those 8 hours of sleep. We need to drink a lot of water. We need to manage our stress, mental health-wise, and just take time to listen to our body. We are very vulnerable during pregnancy, as everybody has just said. And pregnancy is supposed to be a time of, you're supposed to be relaxed and enjoy it. And I think we are in a society where we don't take the time to relax and enjoy the whole pregnancy. We are doing multiple things. And my take home, although it was 19 years ago, is basically just listen to your body and take time for yourself, relax and enjoy the pregnancy that you are having.
As we pointed out, there's a lot of reasons why you want to see your doctor, be seen regularly, have a good relationship with your doctor. Do not be afraid to discuss anything that feels uncomfortable for you or abnormal or just not right. There are things that we can do to help reduce risk of preeclampsia and preterm delivery complications, but we can't do it if you're not in to be seen. So it's important to just listen to your body, try to take the best care of you that you can, but also work as a team with whoever's on your care providing team to do the best for your pregnancy.
Thank you for listening in today. Weren't you inspired, encouraged, and uplifted? We hope so, because we're praying the best for you. Join us again next time for more betterment, because the better you are, the better you are.